Great. So my job over the next 10 minutes is really to sort of cover some concepts that guide the indications for chemo and radiation therapy for chondrosarcomas. We certainly know that chondrosarcomas span the anatomic spectrum with regards to where they arise in the skull base. And as you've seen with the discussions today, we've gotten a better handle in terms of the indications for some of the different surgical strategies for the management of the spectrum of chondrosarcomas. But they also span the spectrum with regards to histopathology. And when you look in the skull-based literature and also the musculoskeletal oncology literature, it's really unclear what the indications for radiation and chemotherapy are with the management of chondrosarcomas. And this is certainly further complicated by the availability of different chemo and radiation modalities, and also the sequence of these modalities around the time of surgery. Within the skull base, we know that there are three different histologic subtypes that occur: conventional, mesenchymal, and dedifferentiated. And the conventional subtype chondrosarcs are further broken down into three different grades. And when we looked at our own experience, and this is in line with what's been reported in the orthopedic literature, the mesenchymal and dedifferentiated chondrosarcomas have much poorer prognosis in comparison to the conventional subtype. And then when you look at the conventional subtype chondrosarcs by grade, on one hand, you have the more indolent grade 1 chondrosarcs. And in these patients, we don't radiate them. And you can see with that strategy a median PFS of 175 months. But on the other end of the spectrum, you have the grade 3 conventional subtype chondrosarcomas that have a PFS that is slightly better than the mesenchymal and dedifferentiated chondrosarcomas. And so you can see that there is this clear correlation between histologic subtype, grade, and prognosis that really should be considered in managing these tumors. And there's also differences with regards to the patterns of recurrence that you see with chondrosarcomas. So take, for example, this conventional chondrosarcoma that I treated early in my practice. When these patients recur, all the recurrences are local recurrences. These patients at first recurrence do not tend to develop systemic metastases. And so the goals of therapy for a conventional chondrosarcoma is predominantly local control. And that's why the conversation really revolves around the use of radiation therapy around surgery. On the other hand, the mesenchymal and dedifferentiated chondrosarcomas. This is a 7-year-old with a mesenchymal chondrosarcoma that I treated a while ago. And when she presented, she had no evidence of recurrence locally, but had pulmonary metastases. And we know that the mesenchymal and dedifferentiated chondrosarcomas in our practice, when they recur, 65% of those patients, as a matter of fact, do develop systemic metastases, which is uniformly fatal. And so the goal of treatment for the mesenchymal and dedifferentiated chondrosarcomas is not only local control, but also prevention of systemic disease metastases. And this is the reason why the conversation also includes the discussion of systemic therapy for a newly diagnosed patient. We know that regardless of histologic subtype, surgery has an impact. And looking at the goal of surgery is a radical resection of all invaded bone, and then secondarily resecting any tumor extension into any adjacent soft tissue compartments. When you look at our own experience, a gross total resection or an R0 or R1 resection has an impact on long-term outcomes when you look at the individual histologic subtypes. The question really with the conventional subtype, as you've seen from the conversation earlier, is really what are the indications for radiation therapy? And when you look in the literature, it's actually confusing with regards to interpreting that data because of the combined reporting of chordomas and chondrosarcs, which are really very different diagnoses. And then when you look even at the chondrosarcoma data, there's often a lack of reporting with regards to histologic subtype and grade. And as I've shown you, they span the spectrum. And the conventional grade 1 chondrosarcomas, which statistically speaking are the most common, have an extremely favorable prognosis even without radiation therapy. And a lot of radiation studies often include these. And so this certainly can confound the data. And so the question in my mind really is there a role for radiation therapy for the conventional grade 2 and grade 3 chondrosarcs? And we've looked at that. And as was discussed earlier, there's a French study that has demonstrated this also, is that there's a clear benefit with using adjuvant radiation therapy with the conventional grade 2 and grade 3 chondrosarcomas in our own practice. And then given the intermediate behavior of the conventional grade 2 chondrosarcomas, we've looked at seeing can we be selective with offering radiation therapy. And we looked at the conventional grade 2s from the perspective of extent of resection. And what we found is that after the subtotally resected or the R2 resected conventional grade 2 chondrosarcs, there is a significant benefit with adjuvant radiation therapy. But that benefit disappears when you look at the gross totally resected conventional grade 2 chondrosarcomas over a long period of time. Now, we also know that there are additional factors related to the delivery of radiation therapy that is important for local control with the conventional subtype chondrosarcomas. Dose matters, and the ability to deliver that dose while shielding radiation-sensitive structures such as the brainstem and the mesial temporal lobe structures is important. And so this has implications with regards to surgery, where while of course we want to get a radical resection, at the very least you want to clear disease away from those radiation-sensitive structures. Now, there's certainly a lot of confusion regarding what's the optimal radiation modality. We've seen, similar to surgery, how there's been a advancement in surgical technique. We've seen tremendous advancements with regards to radiation therapy with proton, photon, and even carbon ion therapy. And the question is really what radiation modality is the best? We've certainly seen from the head and neck literature that the differences amongst these radiation modalities may not come down to tumor control rates, but differences with regards to radiation complications. And so certainly a lot of work is needed there with regards to radiation therapy. Now, as I mentioned, with the mesenchymal and dedifferentiated chondrosarcomas, there's the additional worry of preventing systemic metastases. And this is really where the conversation includes the use of chemotherapy. Now, of course, there really aren't any randomized controlled trials done for mesenchymal and dedifferentiated chondrosarcomas, but in one of the largest studies published to date in 2013, what this group did was look at the role of single agent versus combination agent therapy for advanced chondrosarcomas of all histologic subtypes. And what they found was that combination therapy was better than single agent therapy. And they also found varying response rates according to histologic subtype, where the mesenchymal chondrosarcomas had a response rate of nearly 30% and the D-diff chondrosarcs of nearly 21%. And this certainly drives our own practice at MD Anderson, where we certainly do use chemotherapy as part of the management paradigm. And when we looked at our own experience, there was a near significant improvement in PFS with the use of chemotherapy, either in the adjuvant or neoadjuvant setting, and certainly a significant decrease in systemic metastases in this subgroup of patients. Now, certainly while we use chemotherapy in the adjuvant setting for these patients, I've also come to appreciate the role of chemotherapy in the neoadjuvant setting proceeding up to surgery. And even if you're going to proceed with surgery, I think there are at least 3 reasons to consider using neoadjuvant chemotherapy. First is that, given that these are disease types where there's a high risk of metastatic spread, the fastest way to treat this cancer while you plan for a big resection is by starting induction chemotherapy. And you can almost do that the day after you see them in clinic. The other rationale for using neoadjuvant chemotherapy, even if you know you're going to do surgery, is that for an anatomically extensive chondrosarc such as this one, where you can get a negative margins, but it might be borderline resectable, by incurring a radiographic response with 3 cycles of chemotherapy, this could facilitate a wide margin resection and dramatically improve your surgical outcome. And I think the last rationale to consider neoadjuvant chemotherapy, even though you're going to do surgery, is that by giving that patient chemotherapy before surgery, you then have an opportunity to study the histologic response to induction chemotherapy. And that can guide what's used in the adjuvant setting. And so we look at necrosis rates, and if there's a necrosis rate on final pathology of greater than 90% in response to preoperative chemotherapy, then you know that that perhaps is an effective chemotherapy line to use in the postoperative setting. So to sort of summarize, at least sort of our treatment philosophy here for newly diagnosed patients, with the conventional chondrosarcomas, the primary goal there is for local control. And so we certainly rely on surgery with the selective use of radiation therapy. And so the grade 1 chondrosarcs, uniformly, we just observe them, and we still have a median PFS of 175 months. With the grade 2 chondrosarcs, for right now, we primarily consider extent of resection. Ultimately, I think as Paul indicated, I think molecular markers will play a role in this decision-making, but for the R0, R1 resected tumors we observe, for the R2 ones, we offer radiation therapy. For the grade 3 chondrosarcomas, regardless of extent of resection, we're offering them radiation therapy because of the relatively poor prognosis. And the mesenchymal and dedifferentiated chondrosarcomas, essentially neoadjuvant chemo, surgery followed by chemoradiation therapy. Now, this slide, of course, brings up the issue of which patients you should biopsy if we're worried about histology and how that impacts overall management. And what I would say is that we know that chondrosarcs certainly arise at different synchondroses, and then there's another set of chondrosarcomas that are believed to arise from stem cells responsible for temporal bone development. And the chondrosarcs that you see at the classic synchondroses, uniformly in a newly diagnosed patient, they're conventional subtype chondrosarcs. So there's really no reason to biopsy them in order to plan for their overall treatment. It's these holotemporal bone, multi-compartmental malignancies that we see that are suspicious for mesenchymal and dedifferentiated chondrosarcomas and lend themselves well to biopsy, which ultimately can then guide subsequent management. So that's really sort of what I wanted to cover in 10 minutes. You know, it's a broad topic to cover, but those were some of the concepts that I wanted to cover. Once again, thank you for having me.
That's fantastic. Fantastic, Shaan. Thank you very much. And I think it's building on the views that we've had that show there is a real spectrum in how these tumors are being managed still. And I think combining data sets across multiple high volume centers is probably the way to go in terms of defining some more of the details in terms of molecular basis for our decision making, etc. moving forward. Wouter, Carl, Paul, any of you using neoadjuvant chemotherapy in this setting?
I'm not for, although I think for dedifferentiated, I would. I guess I have not considered mesenchymal to be quite the same as dedifferentiated, but we don't have, you know, a large number of patients to base that on. I'm curious if Dr. Raza thinks that mesenchymal and dedifferentiated maybe do have slightly difference, or is there a crossover between them? I know that's a fine point. We're really going down a rabbit hole in differentiating these, but dedifferentiate, I think, no question, but mesenchymal is a little more challenging. I think to know whether or not to give chemo for.
I mean, they're absolutely different disease entities. I think for the purposes of the analyses, we combine them, but managing them and the expectations are very different. But for both, we definitely consider neoadjuvant chemo. It's just different chemotherapy regimens that we use based on subtype.
I think that's very wise. It makes a lot of sense. Your platform that you put forth as how to manage these, I think, is really helpful and spot on.
I'm gonna bring in Robin now. I'll give you your introduction in a minute for your talk, but I may as well do it now. I can see you've got something to say. So Robin is Professor of Medical Oncology at the Royal Marsden Institute of Cancer Research. He really leads the way in terms of clinical trials for sarcomas here, and previously, before being in London, you were running the sarcoma unit in Washington University, I believe, as well. So have you got something to add here in terms of neoadjuvant chemo?
Yeah, I think it's a really good discussion. I think with regard to mesenchymal chondrosarcoma, the data are understandably retrospective, but there are relatively good, convincing retrospective data from clinical trials to support the use of adjuvant chemotherapy in that subtype. But I fully take Dr. Gardner's point that the evidence base is limited. But I think for that subtype, I would favor the use of neoadjuvant chemotherapy.